All right, we are going to go ahead and call the meeting to order at 12 p.m. For those of you that are joining us virtually, thank you very much. We are using my phone, so bear with us, please, as we may have a few audio issues, but I think we've got it dialed in for right now. Shelley, if we can go ahead and do roll call, please.
Amber Rice.
Dr. Rice and Josh Gaither are here in the vehicle together.
Oh, thank you. Daniel Spate.
Dan's here.
Franco Castromarin.
Present.
Frank Walter.
Here.
Gail Bradley.
Present.
Eve Godstanker. Jason Johnson.
Here.
Josh Gaither, I got you. Julie Augenstein. She's on, isn't she? And Kevin Foster.
I don't see Kevin. Julie, if you are on, if you could please come off mute, just acknowledge your attendance. And then I don't see Dr. Foster currently now.
4, 5, 6, 7,
Oh,
8.
we have quorum.
Yeah.
All right. Just a reminder that this meeting is being recorded, so everything said as part of this meeting will be part of the permanent recording and posted to the Bureau's website. In the packet, there is the attendance report. A reminder, if you missed 2 or more consecutive meetings, the Bureau will reach out to you to determine if you'd like to still participate in the committee. We do have 2 current vacancies. First is for a physician who specializes in severe acute head injury treatment or spinal cord care, or has demonstrated an interest in EMS, as well as emergency physician serving the Western region. These are appointed by the governor. If you're interested in applying, the link to the governor's boards and commission website is on the packet as well. If we can open the slide deck, please. All right, I wanted to start off by recognizing that May is Trauma Awareness Month, and wanted to say a big thank you to all the members of our trauma community for the care that you provide to the citizens of Arizona. So we did do some nice recognition for the trauma committee at STAB this morning, but just wanted to recognize officially as part of Medical Direction Commission all the work that the trauma centers do for the state of Arizona. May 18th to 24th is EMS week. As you can see on the slide, each day has a specific theme, including education, safety, EMS for children, Save a Life, and EMS Recognition Day. I wanted to personally say thank you to all of our EMS providers and their agencies in the state of Arizona. Working in the pre-hospital environment is really a challenging place to work. And there's a lot of things that you sacrifice in terms of working 24-hour shifts, nights, weekends, holidays. And so really thank you for everything you do to serve your community in the state of Arizona. We wanted to also share a proclamation from the governor's office. So a very nice proclamation from Governor Hobbs recognizing Trauma Awareness Month, EMS Week, and EMS for Children Day with the seal for the state of Arizona on that as well. So a big thank you for the proclamation, and wanted to share that with all of our committees. Some staffing updates. I will turn it over to Nicole.
I'll yell so people in the back can hear me. Just want to give some staffing updates. Our last meeting, we had a lot of recruitments and vacancies. So happy to share these updates that we filled many roles within the Bureau. So congratulations to Lihia Castro, who, if for those in the room, she's put her hand up. Many of you probably know Lihia. She has been with the Bureau for some time, and so we're happy that she has accepted the role of certification manager and is already doing great things in that role. As well as Brent Caswell, who is now our permanent enforcement program manager. Brent has been working in an acting capacity for some time and has been an investigator with our team for many, many years. So we're really happy to see him in that role and congratulate him in that promotion. We also are welcoming Stephanie Cotright. She's our newest member of the CON team as our CON administrator. Mitch Adair and Lance Bevins both have been with the agency as investigators in the past, so you will probably recognize their names, but we're happy to say that they are joining the team permanently and our enforcement team is now whole, which is great. And also Monica Ritchie, who's a new member, and she's in the room for those who could see her. She's waving. So she's our new Trauma Center compliance officer, and really excited to have her join the team. It's not on the screen, but we also still have a vacancy, as you may have noticed, with our Bureau Chief of EMS and Trauma System. So that is still an open recruitment. You can find all jobs related to the state at the azstatejobs.gov. Certainly for the Bureau Chief role, if you know anyone that is interested, we are appreciative of you sending them our way, and hopefully we'll have some good news on that role to bring to you in the future as well. I'm going to pass it back to Gail. All right, Dr. Bradley.
Thank you. All right, quickly, just want to cover the Arizona Trauma Registry System update. That is officially transitioning over. If anyone has any questions about that, Carissa is the point of contact. Next for EMS for Children update. Are you going to handle that, Adam? Thank you.
Hi, everybody. This is Adam, and I'm going to give the an update for the Pediatric Emergency Care Coordinator role guides. There was some demand for this because we are recruiting pediatric emergency care coordinators on both the hospital and the pre-hospital sides. And so independent role guides for each of those positions were developed. If you have questions about those role guides, please contact Aubriana Smith. Next slide, Shelley. In addition, we have gone through our grant and established a new deliverable, which is a pediatric recognition program for the emergency medical service agencies. And so we're calling this the MARC program, Making Arizona Ready for Kids. This was approved at last year's EMS Council, the establishment of it, and it's come full circle to this year, where we have recently recognized these 6 agencies as being excellent in their pediatric preparation. They underwent a extensive, I don't want to say investigation, but a review that showed us that they were indeed pediatric prepared. And so those agencies are Arizona Fire and Medical Authority, Central Arizona Fire and Medical Authority, Gila River Emergency Medical Services, Lifeline Ambulance Services, Maricopa Fire and Medical Department, and the Porco Valley Fire District are the first EMS agencies to jump on this program. And so we want to extend our great thanks for you to for applying to that program. Thank you. Next slide, Shelley.
All right, thank you. As all of you are aware, because it was your kind of workload that helped produce this, we are just kind of socializing and continuing to advertise the updates to scope of practice and drug tables. Just a reminder, you guys did all the work, but we are making sure that all of our committee members and the public is aware of the addition of the EMR and critical care endorsement to the scope of practice. We do get quite a few questions about this, especially in regards to medications for hospital-based paramedics. The links to all of these documents will go out with the slide deck, but they're also on the Bureau's main website and the bullhorn at the top if anyone is interested in all right, Julia, do you want to do a quick strategic plan update?
So, we was mentioned at the last set of meetings, we did draft the strategic plan, and that's currently that was approved at the last set of meetings or in September, I guess, and is currently with the governor's office for review. We're currently working on setting up internal and or external work groups for each priority area, depending on the need. And then we will continue to provide updates on our progress at each standing and statutory committee meeting. Some of the things that we have been working on is improving our share program, working on naloxone leave behind. We chose a new trauma registry vendor, so we're getting that set up. Currently continuing to monitor our budget and draft our budget narrative for the next fiscal year, and then continuing to promote the critical care career pathway for workforce development.
Oh, all right, thank you. All right, Adam, for the share update.
Yeah, hi everybody, it's Adam again. An update on share. So in past years, the team at University of Arizona made significant effort to match hundreds, if not thousands, of EMS out-of-hospital cardiac arrest cases to those cases brought into hospital, so we could have a seamless record of an out-of-hospital cardiac arrest. And we've gained a great deal of appreciation for those efforts as we've been as we've transitioned this share program from ownership at the U of A to ownership here at ADHS. And with that transition, it seemed natural to modernize the share program, and two major initiatives at the outset of this to attempt to modernize is one, under the guidance of our DQA team, we are utilizing artificial intelligence and have developed an algorithm that does a lot of that case matching process automatically. So we hope that that automated case matching process improves the speed of data and improves the quality of data. The second modernization that we're targeting is aligning Arizona with national standards, namely the CARES national standards of out-of-hospital cardiac arrest data collection. We're not utilizing the CARES software. We're just asking the exact same questions they're asking, and we're going to pair our data set down to match theirs so we can be included in the national consideration of out-of-hospital cardiac arrest studies. And lastly, I do apologize for the delay in the production of the SHARE report. That isn't to say we haven't made significant progress in steps in producing the SHARE report. But what's important to you is the report itself. And I've gotten many requests from stakeholders for that report. And I promise you it'll be the first thing I do. That the moment I get it is to send it out. So I appreciate all of your patience with that. And if you have any follow-up questions, feel free to email me or my partner, Josie Johnson, about the SHARE program. Thank you.
Thank you, Adam.
Hello, I'll give some quick updates on the EMCT certification side. We have created a questionnaire for all the initial applicants. You can find the questionnaire on the main ADHS website on ImageTrend before you log in, and on your NREMT verification. It's a quick 6-question questionnaire, so that way you have everything ready once you're thinking of applying for your EMCT certification. We also have in there, if you have any criminal history or convictions, please reach out to us before you submit your application. That way we can go over it, and then we can advise you if you should apply now or if you should wait a little bit longer. Also, when you're applying, make sure your NREMT is up to date. We have some instances in which the NREMT has expired. So please make sure that's up to date. The same with having an Arizona state address. Make sure you have one before you apply. And also, if there's a change in your name or if there's any changes on your certification, please reach out to us and let us know. That's in our statutes that you have to let the department know. We have our main EMCT certification email now that you can email us, and one of our team members will get back to you pretty quickly. So if you have any questions, just reach out to us at any point. And then you can also call us and we'll be able to assist you. Thank you.
All right, thank you, Lydia. All right, so we just wanted to share the list of trauma award winners from earlier this morning. So big congratulations to all the awardees, and thank you to the committee that reviewed all the nominations. This was something that we really appreciated the work. The Bureau did not was not the body that was going to review them, but we did have a group that volunteered their time to review the nominations and select the awardees. So congratulations to everyone. And then for our EMCT of the Year Awards, these were nominated via the regional councils. So each regional council nominated one individual to get the award. This is now our second year doing the trauma awards and the third year doing the EMCT of the Year Awards. And as I mentioned during the previous meeting, really as a regulatory body, it's nice for us to be able to take the time to do just some positive recognition and really thank everyone for all the work that they do to support the citizens of Arizona. So congratulations to all of our awardees. Naloxone Leave Behind. I wanted to thank all the medical directors for the support of this program. For agencies to participate, their medical director does have to approve them participating in this program. And so wanted to share some of the numbers. Currently, there are 59 agencies in the state that are participating in this program with about a 50-50 spread between rural and urban. We have had over 4,204 individuals trained. To give you an idea on numbers, this is over 25% of all of our EMS personnel in the state of Arizona are trained in naloxone leave behind. So this is really pretty amazing. I think when we did this grant, we were not expecting numbers anywhere close to this. As many of you are aware, I think the when you look at getting naloxone into the community, we know that this program not only saves lives from the overdose, but it also increases those individuals potentially entering recovery. And there's good data to support that. So getting this out there to our EMCTs, getting them comfortable with this program is really impressive. We are seeing the number of kits scanned going up quite a bit. We had a slow, steady increase for a while, and as more agencies are participating and more individuals get comfortable with this program, we've shipped out over 5,000 kits and over 1,000 have been scanned. What it means when I say that they've been scanned, it means that they've scanned that little QR code you see in the red baggie, which means they've given this out to someone in the community. We are trying to remind agencies that the QR code is the same across all bags. So if your crew accidentally gives a kit out and forgets to scan it real time, they can still go back and scan another kit and we will still be able to collect the data. Because we wanted to make this as low barrier for implementation, we are only looking for 2 data elements. We're looking for your agency. That way we can restock your unit with naloxone, and then the zip code. The zip code is really important. So that way we can kind of track where this is affecting our community and where we can do more resources. So a big thank you to everyone for their support of this program. Our EMS and trauma data dashboards, the EMS data has been updated through 2024, and the trauma data is through 2023. A big thank you to Voxel and her team. I really can't state more how much information is available on these dashboards. The hyperlink to this is available. You are able to query both pediatric versus geriatric or all age groups if you're looking for data. You can query by county or by region to get other elements as well. We do know that there's been a number of agencies in the state that have applied and gotten large grants in the multi-million-dollar range utilizing the data from these dashboards. So if you have any questions about the data, please reach out to Voxel or her team. A big thank you to our EMS agencies and personnel for putting their data into the AZ Pure system and for our trauma registry programs as well. That's is really what allows us to get this data and to produce these reports. So a thank you to everyone. And if you have any questions, please reach out to Voxel or the team about this. And we wanted to mention Angie McNamara is retiring after 23 years with the Bureau. So for those of you who have, probably everyone in the room has encountered Angie at some form, congratulations to Angie on her upcoming retirement. We will be celebrating her on June 26th, and this is open to anyone who would like to participate as well. And May is Motorcycle Safety Awareness Month, and wanted to just make sure we put this out there and to recognize the importance of being aware and keeping our motorcycle riders safe. All right. Next, we will move to our standing committee reports. First, Dr. Augenstein for a TEPI report.
Thanks, Gail. Let's see, meetings from March's TEPI meeting. Adam shared that they're working towards streamlining and automating data for a shared dashboard. Kim provided a presentation on verification trends and understanding ACS exit scores, which was a repeat of the January STAB presentation. And then members voted to approve changes to the member roster, and we'll post rosters showing vacancies. And that was it for March. Thank you.
Thank you. Dr. Johnson for education.
Yeah, so thanks. Minutes were approved, and then Dan shared the pass-fail rates for paramedic testing. We also discussed some gaps in the current rules for oversight testing. We skipped the CYSHCN training item, but Aubriana is in the process of scheduling the fourth work group meeting for that. We approved forming a work group to make STR training modules. The initial work group met on April 25th, but I wasn't able to attend because I'm working. But they did a great job, and they have a plan to have a draft of the RSI training available for the July agenda for approval. That is it.
All right. Thank you, Jason. Next up, Dr. Gaither for PMD update.
I'm sorry, I just got off mute. Can you hear me okay?
Yes, we can. Thank you.
All right, I apologize for the small delay there. The update from PMD is that we approved our minutes as presented. We also, as we will discuss in a minute, approved adding oxygen to the EMR column of drug table 1. We did discuss the optional drug minimums on table 1 also, and we're going to revisit that in July. And then finally, we discussed adding drug profiles for table 1. The discussion really centered around the new drugs for critical care paramedics, and we felt that it was appropriate to focus on drugs listed in the T3Gs for drug profiles, and then leaving those other new medications for hospital or critical care paramedics up to medical directors to develop those protocols. And that's it.
Thank you, Josh. Next, I'll turn it over to Adam for PACES update.
Hi, everyone. PACES last met on March 20, where we met and approved the expansion of membership of the within the bylaws to be more inclusive of individuals serving in pediatric leadership roles around the state. Currently, the committee holds vacant seats for a representative from the Arizona Ambulance Association, pediatric emergency care coordinator from a hospital-based position, a pediatric emergency care coordinator from an EMS agency-based position, a representative from within a hospital trauma program, an at-large EMS representative, a pre-hospital coordinator, a public member, and a representative from a tribal community. Also on March 20th, the PACES committee met and approved the recognition of 6 EMS and fire rescue agencies and departments in the Making Arizona Ready for Kids program, demonstrating their pediatric excellence, as I aforementioned. And lastly, the Education Committee and the PACES Committee are hosting a joint work group to develop children and youth with special health care needs training for EMS providers, and we welcome any and all volunteers. The next work group for that is on June 2nd, and the next PACES meeting is on July 10th. And that's all I have for PACES.
Thank you. All right, next we will move to our discussion and action items. If I can get a motion to discuss, amend, and approve the meeting minutes from January 30th. Thank you, Dr. Castamarin. Thank you, Dr. Walter. All right, we can scroll through those. Any recommended amendments? Hearing none. Any opposed, please say nay. Any abstentions? All those in favor say aye.
Aye.
Thank you. Next item, if I can get a motion to discuss, amend, and approve the draft update for Table 1 to add oxygen to the EMR column. Thank you, Dr. Walter. Can I get a second? Thank you, Dr. Castamarin. Just to give a little background on this, this was something that was requested via some stakeholders as part of the legislation that did add EMR. It included oxygen. And so we wanted to make sure that that was on there. It was an oversight when we did the initial scope of practice. We all somehow missed that. So just trying to close the loop on that. So this was approved by PMD with a recommendation that oxygen be added to the EMR column for scope of practice. So you'll see that on page 4, highlighted in yellow and red, in the middle of the page there. Any questions or comments about that?
I'll move to approve. Ms. Jason.
All right. Thank you, Jason. All right. Thank you, Dr. Walter. All right. Hearing no further discussion, any opposed, please say nay. Any abstentions? All those in favor say aye. All right, that is approved. Thank you. Next is a discussion item. This came from PMD, and we wanted to just bring it a little bit for conversation here before we have this as an action item for PMD, just because it will likely take quite a bit of time if we decide to move forward. So we wanted to get some feedback from MDC before moving forward with this. We had a stakeholder request that when you look at our current drug table, for some of our optional medications, some of them have a limited quantity and others do not. And so the request was to consider if medication is optional, do we want to have a minimum quantity? The one example that they pointed out is if you look at etomidate on page 3, etomidate is listed as optional. However, if you do carry that, you have to carry 40 milligrams. Where that is an issue is if you are carrying medication and we have a minimum quantity listed, when an ambulance goes through its inspection, they then have to carry that minimum quantity. And so one of the pieces that we've gotten feedback from, I'll give as Atominate being a good example, most agencies are capping their dose out at 20 milligrams, and it's not a repeat dose usually, but we have a minimum quantity of 40 milligrams. So looking to say, number one, it's an optional agent, but do we have the right dose for that? When you look at other medications on here, as we've added more medications for the critical care endorsement, some of them are very generic, like antibiotics. And so obviously we aren't going to have a minimum quantity for that. But when we look at things like diltiazem and other medications on here, this would be something that PMD would have to go through line by line to determine, do we want to continue to have a minimum quantity for some of these optional agents? So the group just wanted to get a feel from this committee before they voted on that. So kind of opening that as the background for why this is on there for a discussion for us. Any?
So to clarify, the idea here would be, if I choose the option of carrying an optional drug, I therefore also commit to stocking it in its minimum quantity.
Currently, yes. Yes. So currently, if there's like Atominate, it's a good example. If you say I'm going to carry Atominate, you would have to carry 40 milligrams.
And the ask is that we establish minimum PAR levels for all drugs.
The ask was to eliminate for optional agents because it is optional. So to say if a medication is optional, do we really need a minimum amount because it's optional? So that was the ask. I see Dr. Gaither, you have your hand raised.
Yes, thank you. Can you hear me okay with the vehicle backdrop?
Yes, just make sure I can hear you okay.
I'll move the phone a little closer so that hopefully you can hear better. I do think it would be a tremendous amount of work to go through this and identify reasonable levels. I don't think the work is worth any benefit, quite honestly. I think the benefit to having a minimum supply really should be a medical direction and local consideration. I think if I, as a medical director, were really fascinated by whatever drug it is that's optional and wanted to use that, I would also want to take the time to walk through how much of it should be in my drug boxes. So I would support not adding this and perhaps considering removing minimums from all optional drugs.
Yeah, and yes, I think that was the discussion piece because right now it's a little inconsistent. So we have some optional agents that do have a minimum quantity and others that do not. And so the ask was first, do we want to add them to all the ones that don't? But that I think where PMD was to consider eliminating the minimum quantity for optional agents. But before doing that work, because even that is a decent workload, wanted to make sure MDC didn't have some major objection to that. Dr. Johnson, I see your hand raised as well.
Yeah, I was just gonna say, I agree with what Josh was saying. I think, it's just my own opinion, if it's optional, then there should be no minimum.
Okay. Dr. Walter?
I agree with both of those statements.
Okay, excellent. So thank you. I think that was just really, oh, yes.
Was there a historical reason why minimums were listed for the optional?
I don't know, to be honest, as long as, the 15 years of attending these meetings, we've always had them on there. But as this has grown over time, you can see the inconsistency on the list. You can see some where we do have a minimum quantities and others that don't. I think the initial thought was to make sure that if someone had a medication, that there was enough for safe administration. However, we have our mandatory drug table, and then we also, these are kind of optional things that aren't required. And I think that's the piece which I'm hearing the group is, if it's not required, do we really need to have a minimum quantity? Well, that is helpful feedback. Thank you. I didn't want PMD spending quite a bit of time on this if MDC was going to say, no, we didn't agree with that. So that is helpful feedback to streamline that process.
Hey,
yes.
Gail.
Oh, yes.
This is
Go ahead.
Dan. But this doesn't mean we couldn't theoretically have a drug where a dose that's too low or inadequate for a patient is actually dangerous. We can all think of a half a dozen right off the top of our head. So this doesn't preclude us potentially from having an optional drug that does have a minimum because there would be a safety reason to do so, right?
Correct. The group, I mean, we would,
This would just be the style. The style will be, we don't have a minimum, but obviously if a drug is added to the optional list that actually does have a meaningful safety issue related to needing a certain amount at least, then we still could put that in if we wanted to.
correct. Yes. I think we would hopefully streamline the list a little bit and have less with
Yeah.
the quantity.
Yeah.
Yes. Dr. Walter.
No problem. Thanks.
Thank you.
Just a question, even though we approved it, was how we arrived at 13 cubic feet per oxygen. Like a standard new cylinder is 14.6 cubic feet, the jumbo is like 20.6. So, and this is just for my information. I know we've already approved it. I was asking to approve it at 13.
I don't know. I don't recall us actually voting on that number or when that was approved. I think that's been there a long time. Do you recall when?
That's a long time thing. I don't even know how you calculate 13 feet of cubic feet of oxygen. I mean,
Yeah. And I mean, any of the treatments folks here, you know, standard D cylinders, like more than that. So that might be a historical issue too. So you're going to question about, you know, why do you have them? I was wondering it, but I just wanted to get it approved. Since we're talking about defining things, that might be an issue.
That is definitely something we can add onto the PMD agenda, because I think anytime we can clean things up, that is beneficial. Yes, Matt?
I think at 13, it's small and they go to the end of the gurney. That's at least what Google says. Okay, that's about the same size.
Okay.
So but just something to look at. And again, less than 14.6 was fine. Thank you.
All right. Excuse me. Sorry about that. All right. Well, that is the last of our official action items. If you have any items you'd like to be considered for the next meeting, please let myself or Shelley know. One thing I did want to mention just briefly, there's a new position statement that is jointly published by the National Association of EMS Physicians as well as ACOG regarding management of maternal hypertension. And so I know we spent quite a bit of time at the joint PMD and MBC sessions last spring talking about hypertensive medications, but that has come forward now that there is this new position statement. So we are going to discuss that at the July PMD meeting and then depending what that vote goes, then bring that forward to the September MDC meeting. But just wanted to put that on your radar. If you have not seen those position statements, they are readily available. I know I had them on my agenda as well, and they got an email from several people too. So lots of attention on those, but just to kind of start thinking about that as that has been a big emphasis nationally to improve maternal mortality. Call to the public. Is there anyone that has anything they would like to bring up? Hearing none, there's a list of upcoming meetings on the event schedule listed here. Our next meeting will be September 18th, location to be determined, and our meeting schedule for the remainder of 2025 is in the packet as well. If I can get a motion to adjourn. Thank you, Dr. Walter. All right, thank you. All right. Well, I think that is one of the shorter meetings we've had in quite some time, so thank you.